ఇప్పుడు మనం ఏమన్నా ఈ డోసులు మాకు ఇంజక్షన్స్ డీల్ చేస్తామా? ఎవరు? అచ్చా అచ్చా. అంటే మనకేమన్నా
Are you ready? Hello?
Yes, sir.
Could we start?
Yes, sir.
Right, just a minute. Good evening, everybody. Welcome to this evening episode of Pursue. And this is Pursue 2K, which is lymph nodal pathology. And we are streaming live from Mumbai via Kolkata. A very interesting topic today, which is the pathology of Hodgkin lymphoma. And to talk on that, we have an expert from Mumbai, which is Dr. Kavita Jain. She is an MBBS, BNP Pathology, MNAMS, DCP, Fellowship in Oncopathology from RGCI, Delhi. She is a senior consultant pathologist in the Department of Laboratory Medicine, Max Superspeciality Hospital, Shalimar, Bagh. And she is also, her special interest is breast GI oncopathology and molecular pathology. Before I ask Dr. Jain to start, let me request all of you to please keep your mic muted, your camera off, and please do not share your screen. Just a small correction, we are live from Delhi. So, Dr. Jain, please share your screen. Let's start. Just press present now. Your entire screen. Right, yeah. I can see your screen coming. That's right, yeah. Just now, please make it full screen, please. Just press on that corner arrow. Press hide. Make it full screen, please. Yeah, just share your screen again, please. Yeah, just press that. Yeah, just press your thing. No, just press the PowerPoint. Yeah, fine, right. Don't worry, take your time, Just press that corner arrow, yeah. This arrow, yeah, that's right. Fine, yeah. Make it full screen. Yeah, fine. Please start, yeah.
So, right, good evening, everyone. So, before I begin, I would like to thank Dr. Nadeem for giving me this opportunity. And I hope I do justice to this topic. So, let's start. The pathology of Hodgkin's lymphoma. Hodgkin's lymphoma commonly comes to the attention of morphologists with an unmistakable image of this gigantic atypical cell, and which is seen looming over the sheets of small mixed inflammatory cells. This cell is the Hodgkin-Reed-Steinberg cell, which has a peculiar resemblance to the owl's eye. And the scary look of this owl, will throughout the entire life, throughout our entire career, we won't be able to forget the RS cells. And that actually happens. So this owl has not only been seen associated with Hodgkin's lymphoma, it also has become a scholar by, making research in fields of pathology and also in radiology, where it could find some more conditions, like we could, compare its eye appearance to those cells. So the other conditions are the intranuclear inclusions in cytomegalovirus infections. Then the next we come to the modified macrophages or the Anichkov cells in Ishkov nodules seen in rheumatic heart diseases. Then we have atypical cells, pleomorphic atypical cells in inflammatory myxofibrosarcomas. And again, in radiology, This is a case of cerebral hypoxia where the MRI reveals these lentiform nuclei in basal ganglia, again having the appearance of owl's eye. So these two conditions are not difficult to differentiate because the inflammatory myxofibrosarcomas will have the most commonly they'll be seen in soft tissues, subcutaneous tissues, and we have a lot of pleomorphic spindle cell background with mesoid areas and all that stuff. And in rheumatoid heart disease, of course, we have the convincing history of rheumatoid heart disease. We'll have a tissue from myocardium, etc. And we don't have any mitotic activity. Now coming on to the CMV. So it is a commonly asked question, how do we differentiate between the intranuclear inclusions of intranuclear inclusions of cytomegalovirus and RS cells? So if we move from inside out, we see that these, first of all, they are not nucleoli, they are inclusions, and these are nucleoli. So in a CMV inclusion, we see that these nucleoli are basophilic, they are at least half the diameter of the cells, and they have a very good, clear-cut perinuclear clearing, peri-inclusion clearing, the nuclear clearing. Whereas the RS cells have a prominent nuclear, and the nucleoli is mostly the size of a large lymphocyte. And we don't see any typical or prominent perinuclear clearing. So apart from the morphology, the cells can be big, they can be small. It's difficult at times to differentiate on the basis of the size. But the very characteristic feature of CMV inclusions is the basophilic granular inclusions in the cytoplasm, which we do not see in RS cells. So I have tabulated the differences, and of course, these are all which I enumerated. But of course, we should also go by the clinical history, where if we see the RS cells, we'll generally find a young patient who's like with lymphadenopathy and no other morbid features. And whereas if we are looking at the CMV inclusions, we generally have an immunocompromised patient, and mostly it will be an organ biopsy. Now, before we proceed to the morphology and other details, we should know from where this word Hodgkin's arose from, and earlier it used to be called as Hodgkin disease. Why? And how do we got the name RS cells or the Reed-Sternberg cells? So Thomas Hodgkins, a British physician whose name echoes in the world of medical schools almost every day, he coined the term Hodgkin's disease in 1832, and he recognized that tuberculosis coexisted in some patients. However, later he noticed that the lymph nodes which are involving Hodgkin's disease were more firm, they were more bigger in size. So he finally came to the conclusion that they are different diseases. And then he also pointed out the disease spreads to the contiguous lymph nodes in an orderly manner, and splenic involvement is late. So, which is now, we are still following the clinical criteria, and our clinicians generally, they say that if we have a contiguous spread of lymph nodes, we would first think of Hodgkin's lymphoma. So how brilliant he was. So his work was published in one of the papers by this name. Apparently he did not use the microscope because of the the techniques were not good at so good at that moment. So no histologic description was given at that moment. However, soon many investigators thought to jump in and look at the tissues of these Hodgkin's patients when the microscope became available. So the most thorough descriptions of the Jain cells were given by Carl Sternberg and Dorothy Reed. However, Reed was I have just gone through her life experiences, and she's a very brilliant lady. And most of the work was given by Dorothy Reed, and she clearly distinguished Hodgkin's disease from tuberculosis on the basis of the morphology. Although, still, she thought that it is an inflammatory rather than a neoplastic process, and that is the reason why the disease they called it as Hodgkin's disease and not lymphoma. So she also drew the illustrations herself by looking under the microscope and see how accurate they were. So the Reed-Sternberg cells we got from here, and the eponym that survives to the present. Now, coming on to the present classifications and how do we get the name. So Okay, how do they got the name lymphoma? So now in later half of the 20th century, what happened was we got the cytogenetic studies, and the RS cells were isolated from the tumor tissue, and the molecular studies were done on them, and they found that they are of clonal origin and they are neoplastic in nature. And so officially they coined the term, they renamed Hodgkin's disease to Hodgkin's lymphoma in the late half of 20th century. So so how do we define classical or Hodgkin's lymphoma? It is a monoclonal lymphoid neoplasm, and in most instances derived from B cells, composed of mononuclear Hodgkin's and multinucleated Hodgkin-Reed-Sternberg cells, residing in an infiltrate containing a variable mixture of non-neoplastic small lymphocytes, eosinophils, neutrophils, histiocytes, plasma cells, etc. And we should be like, these are the most important cells. The background cells are even more important because this is the only malignancy in which the tumor mass is not due to the number of malignant cells, that is the RS cells. They just account for 1 to 2% of the infiltrate, or in some biopsies which are very small, they may be just 0.1% of the infiltrate, 0.1 to 10% they say in the literature. So this is how the classification has gone over years. Primarily, again, there was a strong association with granulomas and paragranulomas. So Jackson and Parker in 1944, they had this classification, which again modified, and then we finally had this classification, the latest WHO classification, where we subdivide the Hodgkin's lymphoma into nodular lymphocyte predominant Hodgkin's lymphoma, which will be dealt separately, and the classical Hodgkin's lymphoma, which has been further divided into 4 subtypes, that is nodular sclerosis, lymphocyte rich, mixed cellularity, and lymphocyte depletion Hodgkin's lymphoma. We all are, in a routine practice, we are aware of the Hodgkin's disease. We are able to diagnose it also. So morphology, and now since we have a good immunophenotyping, the diagnosis is not a problem most of the times. But on a daily routine, we just forget to know how these cells, they acquire the peculiar phenotype, and what is the pathogenesis. I think we should have a brief discussion on the pathogenesis too. So the pathogenesis, or the cell of origin of Hodgkin cells, has been in controversy for many years. Now, this controversy was generally when the cells were isolated, the RS cells were isolated, and the molecular studies were done on them, it was confirmed that they are of B cell origin. So before we go on to the pathological aspect, we should also learn about the B cells, the dynamics of B cells in a germinal center, and that it would make easy for us to understand how the pathology or how the RS cells are actually known to originate from the germinal center B cells. Now, normally when an immune or an antigen comes and attack, then early immune response takes place. The naive B cells, which have the immunophenotype of, they have the IgG antibodies, that is IgM and IgD, mostly IgM and IgD. They get activated and they come in contact with the specific T cells along the internodular or the interfollicular area, that is the junction. And when note to be made that mostly the primary follicles, they are devoid of any germinal center initially. So once the B cells get activated, with the help of BCL6, the transcription regulator, they move into the follicle, the center of the follicle. And over so many days, they just keep on proliferating the centroblast. They differentiate into blasts, and they just keep on proliferating. And then they form the central follicle, the germinal center. The germinal center is divided into the dark zone and the lighter zone. Of course, the dark zone comprises of the dark hyperchromatic cells, and the lighter zone, as the morphology, as the name suggests, comprises of light open chromatin cells. So these blasts, when they keep on dividing, they also acquire certain mutations by the process of somatic hypermutation in the immunoglobulin light chain, the IgV area where you have the antigen binding sites. So by this somatic hypermutations, a lot of recombinations occur, and this results in high affinity B cell receptors on these B cells. So the more the antigen present on the B cells, the more it will be presented to the FDCs, to the T cells, and the more better immunogenic response. So definitely high affinity receptors we get from here. Now that from the dark zone, they move to the lighter zone. In the light zone, we see that these B cells with high affinity receptors are recognized. They present the antigens to the MHC complex with the help of the MHC complex 2. They present it to the T cells, the T follicular helper cells, and then the co-stimulating molecules like CD40 and CD40L, when they join together, a lot of cytokine release and a lot of signaling happens the downstream pathway, and various processes occurs. Like these B cells can differentiate into plasmablasts, which will produce antibodies for further use. They can remain as memory B cells, which on antigenic stimulation can produce B cells, or a very effective, another mutation takes place in the heavy chain now. Earlier, it took place in the lighter chain. Now it will take place in the heavy chain. That is the class switch recombination. That is, now initially, as I told, that the G cells are naive cells. The naive B cells have IgM. They possess IgM, which is very short-living. So the class switch has to happen so that the antibodies which are forming, they become long-lived, which are more potent. That is IgA, IgG, IgE. So the class switch recombination occurs, and they become more. This is called as antigen diversification, antibody diversification. So the other pathway which happens is they can recirculate, acquire more mutations, come back to them, and this cycle can go on. Now finally, when some B cells which have low affinity receptors, or the B cells which have just finished their function, they undergo apoptosis. Now there can be some, this is fast mediated apoptosis, there can be some crippling mutations or nonsense mutations which can occur in these pre-apoptotic germinal center B cells, which can prolong the life of the B cell. So why I am telling you all this story is, now mostly it has been shown that the RS cells are of B cell origin. So how did they get it? Because when they studied the molecular genetics, they found that these cells carry IgG heavy and light chain gene rearrangements, that is, which both are occurring in the germinal center. So they are germinal center B cells, and detection of somatic hypermutations again in IgG genes demonstrated a derivation, again the same thing. And finally, the detection of these crippling mutations or the nonsense mutations which occurred in the pre-apoptotic germinal center B cells were also found in these cells. So now they were very sure that they are arising from germinal center B cells. So they should have the characteristics or the phenotype of a B cell, that is CD20 positive. But now we have a puzzling co-expression of the phenotype. That is, we have near complete loss of B lineage markers. We never see CD20 may be seen in 15-20% cases, and they are mostly an aberrant expression. But there is loss of B lineage markers. Only the retained B cell transcription factor we see is the PAX5, and that too we see is very mild to moderate intensity or a heterogeneous intensity. They have a prominent expression of CD30Y, and they can express lineage inappropriate markers like T marker, myeloid marker, and dendritic markers. So this is the reason why. Along with the somatic hypermutations and all, there are other mutations which are happening in these pre-apoptotic, the crippling mutations which are happening with these cells. That is, there will be downregulation of transcription factors for B cell genes. There will be upregulation of transcription factors that suppress B gene expression. There will be epigenetic silencing of B cell genes. So these all together just, knock out the B cell markers, and we don't see any B cell markers in our Hodgkin cells, the classical Hodgkin cells, not the NLPHL. And also, these cells are known to link to the extrafollicular CD30 plus cells. I mean, we go back to the diagram. Mostly, the CD30 follicular cells are those cells which are present normally in tonsils, and they are located at the extrafollicular area. They acquire the MYC gene, they acquire the CD30 expression, and so they have been found, the RS cells have been found to similar to these extrafollicular cells, which easily manage to escape apoptosis. They are just normally present, very scattered population in tonsils, not anywhere else. So if they are there, they are abnormal. Now, very popularly, we see the EBV. We just keep talking of EBV, check EBER, check LMP, IHC in these cells. Why? Because what is the role of EBV in these cells? Again, EBV, besides a few other viral genes, two latent membrane proteins are expressed, LMP1 and LMP2A. LMP1 mimics an active CD40 receptor, that is CD40L, which we have just seen on the T follicular cells, and LMP2A mimics BCR signaling, that is on the B cells. So when both of them come together, they activate the B cells, they prolong the survival, and they deactivate, they just deregulate the apoptotic pathway. They just prolong the survival, some crippling mutations. In NLPHL, however, they maintain the decorum of the germinal center B cells, and they express the general B markers. And again, the molecular studies reveal the somatically mutated IgV genes also genetically demonstrating their GC experience. So they have, in nodular lymphocyte predominant, they have the retained B cell markers. Now coming on to the diagnosis. First of all, the clinical features. Now, this is just the ones I have, what we normally see, and we should know about them. We should always be, before we just start to make the diagnosis, we should always be aware of what site biopsy we have received, because it does help us in making the diagnosis at sometimes when we have confusing morphology and immunophenotyping. And we should know about the B symptoms. We should know whether the extranodal disease is there. I mean, we should definitely know about the site. So they are painless and slowly progressive lymph nodes. Pain in lymph nodes, however, characteristically may occur with alcohol consumption if the patient gives this history. Commonly involved sites are axial lymph nodes, cervical, mediastinal, axillary, paraaortic, and they are rarely seen in non-axial lymph nodes. Primary Hodgkin's, like mesenteric, epitrochlear, or Waldeur's ring, is absolutely rare, less than 1% cases. These symptoms can be seen in up to 40% cases. And primary extranodal disease is rare, that is in lung, liver, or bone. So if we just see according to the subtypes, nodular sclerosis usually presents with a mediastinal mass, stage 2 disease, and they are bulky mediastinal masses. And mixed cellularity, lymphocyte rich, they all have peripheral lymphadenopathy. However, lymphocyte depleted is an aggressive clinical course. So what are the materials we can get for diagnosis? Of course, FNAC is less sensitive and less specific. Now I hardly see any, re-diagnosing. And we can say that there are Hodgkin cells, but of course we need the support of the biopsy. So core needle biopsy should be acceptable in deep-seated lesions, although we see our clinicians in a habit of, giving us just true-cut biopsies from the cervical nodes too. Although we should always ask for excision biopsy, which is the gold standard. Then in cases like mediastinoscopic biopsies and EBUS guided biopsies, of course we have scarce material, but that is the only material available in some cases. Now confirmation of diagnosis should be followed by standard staging. Of course we all are aware of this term, Ann Arbor staging, which was initially done by lymphangiography and splenectomy. You must have heard that they used to do splenectomy for staging and all. But since the advent of PET-CT, we are more, the patient is definitely has an advantage over this. So I'll not go into the details. We have stage 1 with single lymph node, stage 2 with 2 or more lymph nodes on the same side of the diaphragm, stage 3, 2 or more lymph nodes above and below the diaphragm, and then widespread involvement of multiple organs. E, that is extra, when we are diagnosing Hodgkin's lymphoma in some extranodal site, primary Hodgkin's lymphoma in some extranodal site, it should be done with great caution, because if we look back at the literature, it has been observed that those cases which were assigned as Hodgkin's lymphoma, the extranodal Hodgkin's primary, came out to be as non-Hodgkin's and or EBV-related lymphoproliferative disease. So I don't say that it cannot happen, but it should be given with great caution, including all the clinical and radiological details. So what is the diagnostic armamentarium we have? First and foremost is the morphology. So the morphology, we have two cell populations, that is the RS cells or the variants of RS cells and the LP cells in NLPHL, and the variants of on morphology. And of course the background milieu is again very important diagnostic part, as most of the tumor mass is formed by the this cellular milieu. So we have the classic RS cells, which are bilobed, they have mirror images, prominent nucleoli, and just like an owl-eye appearance. They can be, the mononuclear RS cells are known as Hodgkin cell. They can be seen in all types of classical Hodgkins. Then the mummified RS cells, we have a pycnotic nuclei. We don't have a discernible nucleoli, and of course it is retracted, the cytoplasm. So these are mummified, and they can again be seen in any of the varieties, subtypes. Then lacunar cells are characteristic of nodular sclerosis Hodgkins. There we see that there is abundant cytoplasm and there is cytoplasmic clearing because of the fixation artifact. Formalin-fixed specimens generally show this clearing. And the nuclei are polylobulated, polynuclear. At times, if they can be so small, with small prominent, the nucleoli is not as large as in classic RS cells. It can be small. So we need to be extra cautious for diagnosing these cases, and they can be multinucleate lacunar cells also. And then there can be pleomorphic RS cells, which are more commonly seen in lymphocyte depleted classical Hodgkin's lymphoma. Now, LP cells are, if you can just make out, these are the cells which resemble we must have heard popcorn cell. They resemble the exploded kernel of corn, and they are polylobate, they are multilobated small prominent nucleoli. So again, neoplastic cells are 0.1 to 10% of the cellular infiltrate. Now coming on to the immunohistochemistry. Now the second diagnostic tool is the immunohistochemistry after the morphology. So again, we know, we all should be aware that we have the panel, the first panel we put as 15, 30, 3, 20. Generally we put these markers along with PAX5. So very characteristically, the LNH cells or the NLPHL, the LP cells would be negative for CD15 and 30, and they would be positive for CD20 most of the times. And the very characteristic feature of NLPHL would be the activated T cell marker, that is CD57, would be forming rosettes. The T cells in the milieu would be forming rosettes along the LP cells. However, the CD57 would be negative in the LP cells. But here we won't find any rosette of the activated T cells. So just to show you, sorry, they're very dark. If we compare for classical Hodgkin's lymphoma and nodular lymphocyte predominant Hodgkin's lymphoma, CD45 is most of the times difficult to interpret because it has been seen that the antibody, they generally leak from the surrounding milieu, it can leak and it can show false positivity of the large cells. But still, if with an experienced eye, we can make out CD45 negativity in classical Hodgkin's lymphoma, and it does help, when we are stuck somewhere. So CD45 is positive in NLPHL. CD20 they're showing just a mild aberrant expression. This is all negative. However, they are very strongly prominent by CD20 NLPHL. CD30, of course, in classical Hodgkin's. And this is the characteristic PAX5. For so many years, I was not able to interpret how do we do PAX5 interpretation in Hodgkin's lymphoma. But then I got to know it can be a heterogeneous staining because obviously the B cell antigens are lost. So this is one of the markers which is remaining. So we have a very weak to mild staining of the backside. Whereas if it would have been a strong staining, it would have favored some non-Hodgkin's lymphoma or some NLPHL or something else. But this is the characteristic staining of classical Hodgkin's lymphoma. So the third and the last we have is the detection of EBV. In most of the cases of classical Hodgkin's lymphoma, we can see EBV, we can detect EBV. However, most commonly it is detected in mixed cellularity Hodgkin's lymphoma, that is 70 to 75% cases, although it is not always required for the diagnosis. It is not always essential for the diagnosis, because again, it can be there in other benign mimics of like infectious mononucleosis in lymph nodes. So helpful in mimics from classical Hodgkin's lymphoma, it can help us to differentiate from NHL, like ALK positive large cell lymphoma and primary mediastinal B cell lymphoma. And also sometimes it will help us to know the subtype, because as we say that mixed cellularity Hodgkin's is most commonly associated with EBV detection. So the techniques used are IHC for latent membrane protein, that is LMP1. And when we put the IHC, we see a membranous staining of LMP1. And in situ hybridization for EBV encoded RNA, that is EBO1, EBRISH, which we commonly hear of, we see the nuclear staining. So this is the nuclear staining we have to see for. And of course, PCR can be done, but commonly these two techniques are routinely used. Now, coming out to the pathology of classical Hodgkin's lymphoma, we're actually deep diving into the Hodgkin's lymphoma. Nodular sclerosis Hodgkin's, it is the most well-recognized, most easy to recognize subtype. It is characterized because of by the virtue of the collagen bands that surrounds at least one of the nodules, and along so we have the nodules, we have the RH cells, that is the lacunar type morphology, the RS variant cells, and the collagen bands. It is the most frequent subtype, constituting 75 to 80% of all cases. Most patients present with limited disease, and as I told you earlier, mostly they have an Arbor stage 1 or 2. These symptoms are just around in 40% cases. Again, as I mentioned, mediastinal involvement occurs in 80% of cases, and usually it is a bulky disease. It peaks in 15 to 34 years of age, and it has the better overall prognosis than other subtypes. So coming on to the pathology, so we have broad collagen bands originating from the thickened capsule. These collagen bands originate from the thickened capsule, dividing the parenchyma into nodules. So depending on the amount of collagen, we can have a cellular phase, that is just all the cells only, and we don't see any collagen band. We have the typical RS cells or the lacunar cells, and we don't see any collagen bands. We have early sclerosis, where just one nodule or part is seen either partially or completely encircled by collagen bands. We have classical sclerosis, where several nodules will be there. And we have total sclerosis, where we have complete obliteration. Now, this is just for an extra information or easy recognition. So if you can see here, this is a lymph node with the low part, where we have the nodules divided by the collagen bands. And this is the intermediate part, which can show us the nodules. However, we cannot see any germinal centers, and we have the collagen bands. These collagen bands, they are said to show green birefringence on polarized microscopy, and they are one of the diagnostic pathognomic features, because although these nodules can be seen in other subtypes like lymphocyte rich Hodgkin's lymphoma or NLPHL, but we won't see any sclerosis or fibrosis in those lymph nodes. Now coming down to the high part, we have these lacunar cells. Again, as I told you, they have a clear cytoplasm. Lacunar cells, they can be multilobated, they can be binucleate, mononucleate. Now, these are obviously positive for CD30. Most of the times the problems are solved by CD30. I've noticed this most of the times, even when there is scant material. Then again, CD45 interpretation is very difficult, but still with experienced eye, we can say that these cells are negative. CD3, as I told you earlier, the CD3 activated marker, that is CD57, is making rosettes in NLPHL, not in classical Hodgkin's. But of course, the background of classical Hodgkin's, there's a lot of T lymphocytes in the background, which seem to form rosettes. So these are CD3 rosettes around the lacunar cells, and we see the CD20 cells are sparse in the background. Now, the British National Lymphoma Investigation of the BNLI grading of nodular sclerosis gives a two-tiered grading based on the proportion of these RS cells and the background infiltrates. Grade 1 is the most common, and it will show nodules which are containing these lacunar cells in a background with varying proportions of inflammatory cells. But now when the disease progresses and more lacunar cells grow, more than 25% of nodules will show bizarre pleomorphic RS cells. The criteria is either more than 25% of the nodules are showing bizarre pleomorphic cells, or more than 80% of the nodules show a fibrohistiocytic component. However, this grading is not strictly required for routine clinical purposes. We are not reporting it. It is more for research protocols. Again, morphologically, we can divide nodular sclerosis Hodgkin's into cellular phase and syncytial phase. They have a clear tendency to nodule formation. Of course, as I told you, cellular phase will not have any collagen bands. The lacunar cells are visible scattered. And in syncytial phase, there will be large sheets of neoplastic cells. It has an aggressive clinical course. We can mention in our biopsies that the patient has nodular sclerosis is in syncytial phase, depending on the criteria as I told you. And mostly it correlates with mediastinal bulky disease. Now again, these nodular sclerosis Hodgkin's are also seen to be commonly associated with necrotizing granulomas. Recently, I have seen a case of a 15-year-old boy who had a mediastinal mass and a cervical lymph node. So we got a true-cut biopsy from cervical lymph node where a lot of necrotizing granulomas were there. Absolutely this picture. And in this milieu, we have to, specifically with a patient who's giving a history of mediastinal involvement also, or a mediastinal mass also, we should definitely look for these cells, because lacunar cells can at times look like normal reactive histiocytes also. So no harm in putting a CD30 and CD15 in these cells, so that we are absolutely sure that at least the biopsy which we have received, we are not looking. We have not found any RS cells, and I did the same for this patient, and luckily this patient, at least in that true-cut biopsy, there were no CD30 plus cells, although I was a little jittery before just ruling it out. So what are the differential diagnoses? We have anaplastic large cell lymphomas. Those cells which can be CD30 positive, those entities which can be CD30 positive and which have a mediastinal mass, a primary mediastinal large B-cell lymphoma. So as the name suggests, this will also have B-cell antigens. So of course it is easy to diagnose. Then anaplastic large cell lymphoma, again, we see that they are CD30 positive, but they will definitely be PAX5 absolutely negative. The slide will be clear of PAX5, so that helps us in differentiating. And of course, we also put EMA in our regular panel, to rule out ALCL. And of course, LCA will be positive. For mediastinal germ cell tumors, of course, the inguinal carcinomas can be CD30 positive, so we can put a hierarchy marker, that is SAL4, which will help us to delineate that they are germ cell tumors, and they are of PAX5 negative. And when we rule out everything else, we should definitely go in for some metastatic undifferentiated carcinomas, where we would get CK, if not all these antibodies. Coming on to mixed cellularity. So this is a subtype of classical Hodgkin's lymphoma with scattered RS cells and a diffuse or vaguely nodular mixed inflammatory background. There will be no sclerosing fibrosis. It is the next common variety, 20 to 25% of all CHLs. There is no bimodal age distribution. Of course, peripheral lymph nodes, mediastinal involvement is uncommon. These symptoms are frequent in mixed cellularity, and they are mostly EBV positive. So the subtype, we can remember the subtype which is most commonly associated with Hodgkin's lymphoma is the mixed cellularity. Now, if we see, it is the effaced nodal architecture. Again, we have some, weight nodules, but no sclerosis. Then again, we see a lot of, this is a cellular slide, absolutely a cellular section. And if we by chance happen to see an eosinophil or eosinophils, we should definitely go to the high part to look for these scattered RS cells. Now, a very interesting, I also happen to have, I think I have seen 2 cases of interfollicular pattern. This is one of the most important diagnostic morphological variant of mixed cellularity which should not be missed, absolutely should not be missed. So these are actually focal involvement of the lymph nodes with paracortical and interfollicular distribution between hyperplastic lymphoid follicles, recognized as a focal or early interfollicular involvement in classical Hodgkin's lymphoma. So what happens is at low part, we just see the lymph node and we say it is reactive, and we'll just put a BCL2 probably to prove that these are not follicular lymphomas, and this is no. But I suggest that I think if we have a good clinical history and we should always try to go to the high part and look at the paracortical areas. So, because they are just focal and they have subtle morphological features, so can be easily missed. So the presence of any epithelioid histiocytes or eosinophils are definitely helpful clues. But I suggest that anytime we are looking at the reactive lymph node, we should definitely, just search the interfollicular areas for any atypical cell. And I even don't mind putting a CD30 at sometimes. Of course, if the patient has built for the IHC. And so these are some epithelioid histiocytes we can see in between the parafollicular areas, and so the search was helpful where we could find some atypical RS cells. So again, the differential diagnosis is T-cell rich non-Hodgkin's lymphoma, large B cell. Again, the large cells usually do not resemble the RS cells. They lack the milieu, and in all cases, they are large B cell lymphomas, so they would definitely go for B cell antigens. They should be T30 positive, but we should always do we always do in our panel 3 and 20. Of course, we are stuck when we see any CD20 aberrant expression of CD20 in such cases. So, okay, so the other differential is the PTCL. Now, that I should tell you that PTCL is the Lennart's lymphoma, where we have a high content of epithelioid elements, is one of the, it can become one of the most close differentials, and at times it may be so difficult that we have to, go down to the molecular or the T cell rearrangement studies to differentiate whether it is a PTCL or a mixed cellularity Hodgkin's lymphoma. Although, because they can all have common features. Both of them can have common features. The Hodgkin cells showing CD3 aberrant expression. The T cells, of course, they can show CD30. So it at times is difficult. The soft features which you should keep in mind are that the lymphoid cells in PTCL will have a pronounced irregularity of nuclear profiles. They will be highly pleomorphic and they will have a high mitotic index. Whereas I forgot to tell you in pathogenesis that since the Hodgkin cells are pre-epitotic, they were supposed to go to epitosis, but they were stopped going there. So they are not dividing. So characteristically the Ki67 won't be very high. Whereas in Lennart's lymphoma or the PTCLs or other NHLs, you will have a high mitotic index. So we have ALK again PAX5, the EMA would help us. The lymphocyte rich is again, as the name suggests, is comprising of all small lymphocytes with an absence of neutrophils and eosinophils, and we have scattered HRS cells within the nodules. Initially, it was called as follicular Hodgkin's, but now it has been called as nodular Hodgkin's. Peripheral lymph nodes, again, stage 1 or 2 at presentations. B symptoms are rare. has a similar prognosis to NLPHL and a very close mimic of NLPHL, but NLPHL has a tendency to relapse frequently. We do see cases coming up, in 5 years and 8 years, but generally they are not known to relapse so frequently, lymphocyte-rich classical Hodgkin's. So again, these are closely packed nodules. As I told you, they have NLPHL is one of the close differentials in this. We rule out nodular sclerosis because we don't see any collagen bands here. Then when we put the IHC, we see vague nodules with expanded mantle zones, which is similar feature to NLPHL. However, we also see residual germinal centers with the help of CD23 stain, which is not a feature of NLPHL. And then we find these RS cells, which are CD30 positive. In NLPHL, the large cells, if there is any confusion, the large cells would definitely be highlighted by CD20 and they'll be negative for CD30 most of the times. Now, lymphocyte depleted. This is a diffuse subtype depleted of small benign lymphocytes, and they have numerous sheets of RS cells, and they account for less than 1% of cases. Most of them present at stage 4 disease, the subdiaphragmatic disease or organomegaly is often HIV associated, and they have B symptoms at presentation, and most of the studies say that mostly they are NHLs only, non-Hodgkin's lymphoma. So they have two subtypes, that is the reticuliform, and they more commonly look like a sarcoma. Very commonly look like sarcomas, and just like MFH, the malignant fibrous histiocytomas. But anyhow, whenever you see next time, of course the background is there, and whenever you see it next time, I think we should always put a CD30 in such cases. Of course, the site will suggest us that hypercellular with abundance of pleomorphic large cells and admixed histiocytes. And this is the diffuse fibrosis type, where the background is hypocellular, more of sarcomatoid appearance. We have disorderly fibrosis with amorphous pink eosinophil material containing few cellular elements, and they are CD30 positive. So of course the differentials are anaplastic large cell lymphoma, diffuse large cell lymphoma, nodular sclerosis, classical Hodgkin's type because of this material. However, it is past positive, and of course sarcomas. So coming on to the last entity, that is the nodular lymphocyte predominant Hodgkin's lymphoma. It is a B cell neoplasm characterized by scattered clonal LP or lymphocyte and histiocytic cells in a background of reactive lymphocytes and histiocytes with a mostly nodular and sometimes a diffuse growth pattern. Now they are large cells, they have globular nuclear contours, and they are variably prominent nucleoli which are basophilic. And of course, as I told you, they are smaller than RS cells. They are also called popcorn cells. Now, just rather than enumerating on NLPHL findings, we can just compare the clinical features of classical Hodgkin's and NLPHL. The age distribution is bimodal, whereas in this case it is unimodal. Sites involved are peripheral lymph nodes, mediastinum, spleen, but here mostly the patients present with stage 1 or stage 2 disease, and their peripheral lymph nodes. These symptoms are present in classical Hodgkin's, and it is very rare in NLPHL. They have association with EBV and none not associated. Here again, it would help us. The EBV would help us to differentiate the CHL and NLPHL. They have aggressive course. They have indolent courses, and as I told, patients will present after 5 years, after 10 years. They have late relapses. Risk of large B cell lymphoma is 1%, and here it is higher. So the diagnosis can be strongly suspected on low magnification because the nodal architecture is completely effaced by nodules on nodules and diffuse areas, and they say that at least a single nodule is required for diagnosis. So we see here that there are nodules, of course no sclerosis, closely opposed nodules. They have somewhat a moth-eaten appearance, and there are no germinal centers. Now LP cells, these are the LP cells, these are lobulated like a popcorn cell, a popcorn. So CD20 would highlight these nodules. So we may think that they are reactive nodules, but then as we go to the higher power, we would see that in a background of these CD20 positive cells, the LP cells are more brightly stained by CD20. And this is characteristically seen in we have seen at least 3-4 cases in around 1 or 2 years, and this is absolutely a very pathognomic feature that this CD20, which is staining the background B cells, it will highlight or stain the LB cells very strongly or brightly. Again, the T cell activated T cell markers, that is CD57 and PD1, would be forming rosettes around these cells. So in classical Hodgkin's, although we have CD3 rosettes, but we won't have CD57 rosettes in classical Hodgkin's. And all those markers up to BOB1, the B cell apparatus markers are intact in these LP cells, whereas they are not in classical Hodgkin cells. So depending on the immunostaining and the architectures, they have been divided into 6 immunomorphological or immunoarchitectural patterns, which we just should be aware of because for the completion's sake, they have closely opposed nodules, that is B cell rich nodules. Then they have serpiginous interconnected B cell rich areas. Then we have extranodular, this is the nodule, and we have extranodular LP cells. Normally they are found within the nodules. Then we have T cell rich areas. They are all T cells, they're negative for CD20, they are all T cells, and we have a lot of HRS cells within the T cells, so T cell rich nodular. Then we have diffuse T cell rich, and we have diffuse B cell rich. So these are some of the differentials I've been repeatedly doing. I think you can just go through this table. I've deliberately made this so that it may help you out later. Now, the very close differential to NLPHL is PTGC. Whenever you have NLPHL, definitely there is some discussion on progressive transformation of germinal centers. It is said to be, an early phase where PTGC can be converted into NLPHL. So in PTGC, we will characteristically find that the large macronodules or the proliferated nodules are distributed among the reactive follicles. We can see the germinal centers. Whereas here, there will be no germinal centers. The macronodules are there with a moth-eaten appearance. They don't have any moth-eaten appearance. No T cell rosettes, and here we have T cell rosettes. So this we can, just see only. We can only appreciate when we see the slides mostly, but we can keep these points in mind. So benign mimics of Hodgkin lymphoma are definitely infectious mononucleosis, and we have immunosuppression associated lymphoproliferative diseases, especially with post-transplant cases or methotrexate associated lymphoproliferative disease. So in all these cases, we'll have a typical history in infectious mononucleosis, which is the commonest differential. We have acute onset of fever, pharyngitis, splenomegaly. It is a self-limited but transmissible disease. The overall architecture of lymph node remains intact. There may be paracortical hyperplasia and scattered immunoblasts. And by now, you should know that the most common differential would be the interfollicular variant of mixed cellularity. So we have to rule out. We see one thing in common, that although they may be CD30 positive, but these scattered cells, immunoblasts, are also maintaining the B cell apparatus antigens, that is the BOB2, B1, etc. And of course, it is self-limiting. Now, most commonly, these immunosuppressive lymphoproliferative diseases are seen at extranodal site. As I mentioned during the staging 1E, that the classical Hodgkin's, primary classical Hodgkin's at extranodal sites either turned out to be NHLs or EBV-associated lymphoproliferative diseases. So they were seen that there was a possible regression with reduction of this immunosuppressive therapy. So now just completing my lecture, just for the sake of completion, I just made this flow diagram. How should you proceed with the diagnosis of Hodgkin's lymphoma? If there is a strong clinical suspicion, and also on morphology, we have a high index of suspicion, with careful examination, we should scan at low power, followed by slow search for RSLs or its variants on high power. In an apparently reactive node, look closely in parafollicular zones for increased eosinophils, histiocyte aggregates, or scattered cells. And if they are suspicious, take additional deep levels. Believe me, definitely, I'll just show you one case the deeper levels proved to be helpful to me with the scant material. And technically, if the whether the sections, whether they are technically satisfactory or not, the section should not be thick. You should never report on thick sections because they obscure the large cells. Should always, lymph nodes, they tend to give us, the technicians tend to give us thicker sections. Artifacts such as poor fixation or crushed artifacts may obscure cells such as transbronchial or mediastinal biopsies. However, IHC can come to the rescue. So this will come later. First of all, I'll come to the routine cases. I'm just discussing the technical difficulties. Now, this was a 55-year-old male who presented to the emergency with complaints of hemoptysis and fever. He was seen by a gastroenterologist, and whatever the workup was, his hemoglobin was found to be 5 g/%. He was referred to a hematologist where he was evaluated for anemia. The bone marrow aspirate biopsy were done, and the patient did not give any history, no other significant history of the past. So bone marrow aspirate findings were unremarkable. Now I'll show you the bone marrow aspirate findings for another bone marrow biopsy. If we see on a low part, generally looks okay to me, over 50, 60% or 70% cellularity. When I went to the intermediate part, only one worrisome feature I could see here, that this is some area which is worrying me, otherwise all of it is okay. Now, when I came to the high part, we have these megakaryocytes, which can again be a differential for HRS cells. There was just one cell I wanted to mark, but just one cell I saw which had a prominent eosinophilic nucleoli, and definitely the clue was the epithelioid histiocytes here. So I just did a CD30, and in deeper sections, see, just one cell in this section, this is the cell with prominent eosinophilic nucleoli, and I could see so many CD30 positive cells. So when I told this to the clinicians, although about the Hodgkin's lymphoma, later on it was found that the patient had Hodgkin's lymphoma 20 years back. So, added to my credit somehow. Then the next case, case 2, he was 55-year-old male, healthy, cervical lymphadenopathy for 2 months, no history of fever, weight loss or night sweats, excision biopsy, got an excision biopsy. The clinician was fair enough to give us the excision biopsy. And here I've included this case just to show you that these are thick sections of the lymph node. I just could not interpret anything. I ordered my technician to give me more thinner sections, more serious sections, and if you can just appreciate nicely, these lymphoid nodules have come up, the vague nodules, and they're showing me the moth-eaten appearance. None of them have reactive germinal centers, and of course when I put my eye, it's the characteristic picture of NLPHL. Now, 40-year-old male presented with cuff mediastinal lymphadenopathy. We received a cell block from the mediastinal node, and just see the low part. Anybody, even I, was like of this opinion. This is negative. We have nothing significant in this. This scant cellularity, a lot of crush artifacts and all. When I went to the high part, some bothering cells definitely were there. Although these were the crush artifacts, and so I kept on convincing myself that these may not be, these are just reactive cells also. But anyhow, they were there in the different fields. So I again put the first panel, that is 3, 20, 30 Pax5 and all, and definitely they came out to be 30 and 15 positive, and the patient was Hodgkin's lymphoma. So I just finished my lecture, and I hope I could make sense. So
you did. It was wonderful lecture, excellently done, very crisp and clear, very smooth, and very nicely put up everything in a very nice manner. It was very good for the residents as well as for the consultants to understand the subject from its historical perspective, from its morphological perspective, from its immunohistochemical perspective, as well as from its differential diagnosis perspective. Very nicely done, doctor. Excellently done. There is a question by Dr. Meenakshi Kamboj. She says, very interesting and informative presentation, ma'am. Excellently done. So very nicely done. There are no questions, there are no queries as of now. Just let's wait for a minute to see if there are any questions on the YouTube.
Yes, sir.
Wonderful show. Excellent. Wow.
Thank you, sir.
Brilliant. It was so smooth and you went with a very nice flow. You really have taken time to compile this lecture. Excellently done. Wonderful.
Thank you, sir. I got a bit late actually 1 week because this COVID family was stuck.
No. That's all right. If we are rescheduling many lectures because of this, I understand it's very difficult for anybody to concentrate on work as of now. Yeah, so there are no questions on the YouTube now. Thank you so much. Thank you so much, Dr. Kavita Jain. Excellent presentation. We would love to have you again with some another topic. I will discuss with you on the WhatsApp.
So I have a query where there are no questions. I think there are just two possibilities which our professors used to tell us. If you have no question, that means you have understood very well. And if you have no question, that means you have understood nothing. So I hope it is an option.
Fine. There is a question right now, as I told you. Could you please tell us a bit about the role of PET-CT?
Yeah, PET-CT helps staging actually. Definitely, yeah, sure. Staging, they help us in staging the disease. Initially, as I told you, they used to do the splenectomies and the lymphangiographies because this staging could then tell us how the therapeutic decisions, the therapeutic decisions would be made on this. The higher the stage, the more bad the prognosis should be. And so PET definitely it will help us in staging, and later on when the patient has been given the therapy, later on they see how the patient has responded. So it both ways.
Right, for staging and for response, absolutely correct. There is another comment by Dr. Garima Durga. She says, excellent talk, Dr. Kavita.
Thank you, sir.
Wonderful. Excellent show. Just let's wait and see if there are any more questions on the YouTube. No, there are none. So thank you, Dr. Kavita Jain.
Thank you, sir.
We would love to have you again on this platform with some other topic of your interest. We will discuss that and then we will
Thank you
put
for
it
this
up.
opportunity.
My pleasure. The pleasure is all mine. Thank you so much. Take care. Good night. Bye-bye.
Good night, sir.
Thank you. Bye-bye.